So this is nasogastric tube insertion, or an NG tube. These are often placed for decompression of the stomach prior to surgery or during surgery, or if your patient has intractable vomiting and needs to just have a bowel rest for a while. So, and they're often connected to suction. So first thing that I want to make sure is I have intermittent suction available, because it's very rarely put on continuous. So you'll see on my dial here I have intermittent and regular. But to test it, I'm going to turn it to regular, and I'm going to turn this down because I want it to be in the low range. So as I'm occluding it, I put it on the low range. There we go, let's cover that. Okay, now, whoa, yeah, we're really high. So I want it to be low. Okay, now I've got good suction. Now I'm going to turn it to intermittent, and you'll hear it go off every few minutes when it's on intermittent. All right, so I've got that ready to go, and I've checked that device. So those are the things that I want to do equipment-wise, and then I'm going to go to my supply room and gather my supplies prior to doing the procedure. So to place an NG tube, of course, I need an NG tube, and my doctor's ordered an NG tube placement. I need to do oral care. Most of the time they vomit, so I want a waterproof pad and an emesis basin. I need to attach it to their gown, so I'm going to get a safety pin, and I can either use tape or I can use a rubber band for that. I need some tape to secure it once it's in. I need skin prep, so I'm going to have that. I need some lubricant. Anytime you put a tube in somebody's body, lube the tube. That's your patient's friend. I need a catheter slip tip syringe to check for placement. I need a straw and some water. And of course, I'm going to take a couple of tissues because he just might tear up. Another thing that I need is my pen light, which I have in my pocket, and a tongue depressor, a tongue blade. All right, so I believe I have all my supplies. So I'm going to come into my patient's room. Hello, Mr. Gastro. How are you? My name's Amy, and I'm one of the nurses that's working with Dr. Emesis, and he asked us to put in an NG tube into you. It's a tube that's going to go from your nose down into your stomach. It's going to decompress and rest your stomach so that we no longer have all of the vomiting that you're having. It's also going to decrease your pain as well. The procedure itself, I'm not going to lie, is not terribly comfortable, but it's kind of necessary at this moment. Do you have any questions for me? None? And I noticed on here that you have an allergy band that says no known allergies. And could you please tell me your Niles Gastro, 2/10/1970? That's your date of birth? All right, Mr. Gastro. I'm going to just kind of explain the procedure to you, and then we'll go ahead and get started. Raining. Okay, so I'm going to do some hand hygiene here. Definitely want to get a couple of pairs of gloves for this. All right. Now, to do this, Mr. Gastro, I need to have you in an upright position, so I'm going to place the head of your bed up, at least at a 45-degree angle. Now, on every hospital bed, if you look below the bed, there's a marker that shows where we're at. And right now, this patient is at a 47.5-degree angle because I'm really good that way. So if you'll see here, here's your markers, and here's your angle. So here's 45 and there's 50, and we're just right in between it. So that's where I need to be. I'm going to go ahead and cover him with a waterproof pad, like so. And I also want to assess his abdomen. So before we start this, I'm going to listen first, because we always listen first on the abdomen, to all 4 quadrants. I'm probably going to hear hyperactive bowel sounds. And then I'm going to palpate. I'm feeling for distension or tenderness as well. So I've palpated and auscultated his abdomen, and then I'm going to go ahead and get my supplies ready. And then I'll explain the procedure to the patient. Now, Mr. Gastro, I want to make sure that you haven't had any recent facial surgery or history of polyps or any fractures to your face or to your nose. If you had, then it doesn't necessarily contraindicate the procedure, but I would definitely use caution. All right, I'm also going to look into my patient's mouth and nose. So I'm going to ask you to open your mouth. I'm going to look in there, and then I'm also going to look up your nares, looking for any deviation or polyps. And I'm also going to occlude each nostril and have him take a deep breath, and ask him if one side is easier than the other for him to breathe out of. He says there's no difference. I'm on this side of the bed, so he's getting it down his left nare. All right, I'm gonna go ahead and get my supplies. I'm gonna go ahead and take this swab right here. This is a skin prep, and I'm gonna go ahead and just kind of wipe this. You might wanna close your eyes have your patient close their eyes while you do this. And you want this to fully dry on the skin, and this helps the adhesive. It gets rid of the natural oils of the skin and makes it so that tape sticks better. So we're going to let that dry. Okay, this tube is going to go down into your stomach. It's going to go through your nose into your stomach. To make sure that I get the correct placement, I'm going to take the tip of the tube to the tip of his nose, go to his earlobe, and then come straight down, and I'm feeling for his xiphoid process, which is where the two ribs come together at the lower portion of the sternum. And that is my measurement. So tip of the nose, tip of the ear to the sternum. So that's what I'm going to mark as my stopping point. This is not a sterile procedure. Our gut is not sterile. We put non-sterile food in it all the time. So I'm just going to mark it, and then this is kind of a hurry-up piece of tape that I can use to attach it. I may need to coil this around a little bit, or I can set it in some ice water to make sure it's a little more rigid if necessary, but this seems to be okay. And then I'm going to give him some water to hold, some ice water, because Mr. Gastro, when we do this procedure, I'm going to have you first look up, and I'm going to insert the tube into your nare going up, and then when you gag, when it hits the back of your throat, and it may elicit a cough or a gag, I'm going to have you bring your chin forward and put it on your chest. And then as you swallow the water, I'm going to insert the tube, and the water will help guide it down, and the swallowing will help. Okay? Sometimes people gag when they get this done. That's normal. And if you feel like you need to throw up, or if it's getting too difficult, raise your hand and let me know. Don't whack me. Just raise your hand and let me know. And we'll also give you this emesis basin. The tube has an air vent. The air vent, it's really important that the air, that you not try to hook this up to suction, because if you do, it's not going to suck anything out of the stomach. This is just for air. So think of the clear blue sky. Keep it clear, and it's blue, and it stays up high. This is the portion that we're going to use to suction stuff out. One of the ways that we can test it is we can also listen for a bubble, and we can look for any gastric contents when we pull back. So this is the setup that I want to have prior to placing the tube. It's marked. It is the clear blue to the sky. I'm going to just put that down there because or actually I can take this and I can put it here on the end of here, because that's my 5-in-1 connector that I'm going to use to connect the two tubes once I take off the catheter tip. All right, now I'm going to lube that tube, because every tube in the body gets lube. Lube is our body's friend. All right, so we lube that up. Okay, going to give you those in case your eyes water or tear up. And then here we go, Mr. Gastro. All right, I'm going to tilt back your head. You've got your cup of water here so that you can drink down. And I'm going to go ahead and I'm going to insert. And he starts to cough, cough, cough. So I bring it forward and I say swallow, swallow. And I just keep working it. I can twist it as he goes. Swallow, swallow, keep going, Mr. Gastro. And we're there, okay? Once the tube is in, I'm just gonna put that quick right there. And that's gonna hold it in place, because when you shove a tube down something, it'll try to, in the body, it'll try to push it out. I'm gonna go ahead, I'm gonna take my stethoscope. Know that this is an evidence-based practice, but a lot of facilities still want you to do it. I would put this here, and while listening over the bulb of the stomach, I hear a whoosh, and that tells me that I'm in there. That's one of the tests that I can use. I can pull back looking for stomach contents. So I see gastric contents would be like a yellowish color. I can also pinch the tube, remove those, take my litmus paper and put it on, checking the pH. It should be acidic. So I can test the pH. I can also do a chest x-ray or an x-ray because this has a radio-opaque line in it, and check for correct tube placement. If my patient can speak and hum, I know it's not through his vocal cords and he's not turning purple or anything like that. Okay, so the tube is in. I'm going to connect them right here. So now it's connected to suction. I want to make certain. I would, of course, give him, get the tears off of his little face. I could do some oral care in here as well because sometimes they can gag or they might even throw up during this procedure. Then the last thing that I'm going to do is I'm going to secure this. How you do this is you take your tube, put your rubber band around it, and then loop it through so that it's connected onto there. And then I ask my patients to turn their head as far to the opposite side as they can of where I'm going to tape it, or I'm going to pin it, so that they're slack. You don't want them to have this pulling on their nose when they're slumped over and falling asleep inside, because it's not unusual for them to the doctor not to want their head to be lower than 30 degrees when they have an NG tube in. So I hook that after they've turned their head all the way to the side so that I make sure that I don't have excess tightness there. And I'm going to go ahead and I'm going to just secure the tube. I've got one going around this way, so I'm going to put it around the opposite way so that it's nice and secure. So I go around both sides of my tube like that, and then I just go across the nose like that. And that's going to secure it. And that is NG tube insertion. Okay, to remove an NG tube, what you would do for that, it's not as bad as a procedure as putting one in, obviously, but the critical criteria is you need to clear the tubing prior to removal because it's got gastric secretions. And if he were to gasp or gag, there's a possibility that he could aspirate some of those contents down. So prior to starting, I want to put in at least 10 mLs of air to clear it, or I could take and put in about 30 mLs of normal saline or sterile water, it doesn't really matter, or just tap water for that matter, because it's going into his stomach. So I gather my supplies, I come in, I tell him it's time to remove it, I turn off my suction, and then I remove my tape, give him some tissues because it's probably going to make him tear up. Again, cover his chest, have the basin handy there just in case it causes him to gag. Remove the pin there, and then remove this. All right, Mr. Gastro, what I'm going to do is I'm going to clear the tube, and then we're going to quickly remove it on the count of 3. So I'm going to take the tape off here. Oh my goodness. There we go. Okay. So I'm going to clear it, and then I'm going to have you hold your breath, and on the count of 3, we're going to take a big breath in and hold it, and 1, 2, 3, hold, out in one swoop, comes like this. Double gloves like that, and goes in the garbage. And that's how you remove one. And then, of course, offer oral care to your patient again. If he's not NPO, you can give him some ice chips and some tissues. And get ready for your supplies. That's NG tube insertion and removal.